Morning and good afternoon. Welcome back to our second day of South Asia and the Western Pacific Bi-Regional FETP COVID-19 online conference. So today we will have two oral presentation sessions. Right now, I would like to hand over to Dr. Thilaka to moderate our first oral session. Dr. Thilaka, please.
Thank you to the chairperson. Good day to everyone. Welcome you all once again for this Day 2 Southeast Asia Western Pacific Bi-Regional FETP COVID-19 online conference. We are in the first session of oral presentation now. I will be moderating this session and we have altogether 4 presentations where we are still waiting for one presenter to join us in. So before starting this session, I would like to remind all the participants or the audience of this conference to kindly mute your microphone if you are not speaking. And if you have questions, you can ask at the end of the session if you are in Google Meet site. Alternately, if you can also write your questions in the chat rooms of Google Meet or YouTube. Please don't forget to provide your name and your agency along with your questions when you are asking questions in the chat room. My final reminder to all the presenters, please keep your presentation within 10 minutes and another 10 minutes will be allocated for a Q&A session. We will make a sound like this. A sound will be produced at the 9th minute of your presentation, indicating that you have 1 minute left to conclude your presentation. Okay, I hope this clarifies the rules and instruction for this presentation. 10 minutes followed by 10 minutes question and answer. Okay, so with this, I would like to invite the first presenter for today's oral session, who is Ha-Linh Quach from MAE Program Australia, to share with us his presentation on in-flight transmission of SARS-CoV-2 during a long-haul flight, result from an outbreak investigation in Vietnam and implication for future air travel. I welcome you, Ha-Linh.
Hi, thank you very much. Can I start now?
Go ahead.
Okay.
Go ahead.
So good afternoon and morning to all speakers and scholars of TEPINET. My name is Quach Ha-Linh. I'm from Australian National University and Vietnam National Institute of Hygiene and Epidemiology. And this is my presentation of in-flight transmission of SARS-CoV-2 during a long-haul flight. Next. So a little bit on the background, as we already know from past and current literature, air travel is contributing to the spread and extent of the pandemic, and COVID-19 is no exception. However, transmission risk from infected passenger to other crew member and passenger or in-flight transmission risk is still very limited in evidence. In early March, we detect a large cluster of COVID-19 cases among air traveling passenger on a flight from London to Vietnam. Next. So a little bit about the flight itself. The name is VN54. This is a direct flight from London to Hanoi on the early morning of 2nd of March. Lasts a total of about 10 hours. We have 16 crew members and 201 passengers on board, occupying business class, premium economy, and economy class respectively. Next. So we actually found the index case of the flight by her own presentation at the hospital. She actually, after a month long living in London and traveling to Italy and France for Fashion Week with her sister, who also later confirmed positive for COVID-19, our index case actually fell ill on 29th of February, but continued to board the VN54 flight in the business class while being symptomatic. After coming to Hanoi, she self-isolated herself, but her symptom progressing until the 5th of March when she has to admit to the hospital and then confirm positive for COVID-19 on the very same day. So the investigation on her case actually start on the 6th of March. Next. So our objective is to analyze the probability that transmission of SARS-CoV-2 actually happened on the flight in question and to identify risk factors associated with it. So next. So whenever we have a case that we have flight travel history like this, we're going to work with Civil Aviation Administration and Immigration Bureau to get the flight manifest, handle it to National Steering Committee of COVID-19 Prevention and Control, who will monitor and transfer it to municipal CDC, police department, and local authorities at provincial level to contact, trace, test, and quarantine all possible passenger and crew member on board. So this applies for all passenger and crew member on the VN54 flight. Next. So for all trace passenger and crew member, with this very basic standard, we're going to check if they have symptoms at contact. We also do standard interview for close contact as well. And we also do contact tracing for this close contact. Next. So if they have symptoms at contact, we're going to isolate them. If they are not, we're going to quarantine them. They're all going to get SARS-CoV-2 testing right away. And if they are negative, they're going to be centralized quarantine for 14 days. Next. So in quarantine, we're going to monitor their symptom daily, and we also test them twice more, one on the 3rd day and once on the 13th day before they exiting the quarantine facility. Whenever they have symptoms, we're going to test them, and whenever they test positive, we're going to isolate them immediately. Next. So this is a result that we have. We found actually 100% of the crew members and 84% of passengers still remaining in Vietnam. So 33 passengers actually transit to other countries by the time of investigation. So we contacted them, tested them, and quarantined them, and we found 15 additional flight associated cases. So here's to remind that we have 16 cases in total on the VN54 flight. 50% being male, 75% being British, and among more than 1,300 close contacts that we all trace and quarantine, we found 5 additional community cases in Vietnam. Next. So this is the layout of the VN54 flight. After we done case interview, we can find that all the index case, the cell in the red, it actually set in the business class with a lot of cluster, a lot of other cases in orange cells surrounding her, making like the attack rate in the business class itself to 62%. We also found 2 other cases in the economic class, and one case is actually a attendance serving in economic class as well. So we can see the cluster very clear in the business class. Next. So seeing the risk ratio of getting SARS-CoV-2 infection in the business class was significantly 7.3 times higher if you are sitting 2 or less seats away from the index case, the symptomatic index case on board. Next. So this is a time course of all the case from index case number 1 to case number 16. We can see here that we found 4 case pairs that they actually travel and set together on the flight, but none of the case pair or individual case actually go like they cross path or meet each other before, after the flight. So the only common exposure here is on the same flight as the index case. And we also found evidence of symptomatic, pre-symptomatic, and asymptomatic case on board. And we found, as you can see here, that we found only 3 people who actually symptomatic before we test and quarantine them. Next. So for the discussion, we have that in-flight transmission hypothesis were really emphasized due to several reasons. In that case, was the only symptomatic person on board. She was with established contact to a confirmed case in her incubation period, which is her sister, who are also residing in London. For all the other flight associated cases, the incubation periods actually overlap with the flight time, which is the 2nd of March. And for community transmission in both England or Vietnam were not widely established at the time of the flight, so make it more unlikely that the case actually acquired infection from before or after the flight, other than like being on the same flight as the index case. So the possible routes of transmission, including aerosol or droplet transmission during the course of the flight, particularly in the business class with a symptomatic index case or contact outside of the aircraft at the airport before or after boarding, and reasoning why we saw another 2 cases in the economy class and 1 case in air attendant class. Next, so we have several limitations that we have. We don't have genomic sequencing data. We don't have environmental sample collected or detailed data of how the case actually activities on the flight. But however, we stand by our implication and results, which is next. We can conclude that long-haul flights can not only lead to the importation of COVID-19 cases, but also to super spreader events of COVID-19. So we recommended and actually implemented in Vietnam on the 21st of March, a systematic testing and quarantine policy for all inbound passengers upon arrival. We also saw in the cluster here that in-flight transmission was well beyond the 2 rows and 2 seat normal definition of close contact case on the airplane that we see very clustered in business class and also in other classes as well. So mask wearing, personal hygiene mandatory on board, health declaration and social distancing at the airport is very recommended and also implemented in Vietnam since 6th of March. Next. So this is an acknowledgement of all the people who have contributing to the study itself. And this study is also published on Emerging Infectious Disease Journal since early October. If anyone who interested can actually go find it in the same name or contact me afterward. Next. So thank you very much for the presentation. This is the end of my slide. So I hope to get a lot of good questions from everyone. Thank you.
Thank you, Ha-Linh, for keeping up to your time. Congratulations, and that was a very good presentation. So we have few questions for you. There's question from Indonesia from Dr. Muhammad Asri. He said, any specific case definition have been used?
Yes, so actually, if you want to ask the case definition for the investigation itself, we actually use a very sensitive case definition at that time that we found all people, so all possible passenger flight on board a VN54 flight who actually have symptoms or don't have symptoms, we all trace them and quarantine them. But for the specific case definition of the study itself, suspected flight associated case gonna be passenger and crew member on the flight with symptomatic compatible to COVID-19, and confirmed flight associated case on the flight would be whoever a passenger or crew member on the flight who tested positive for COVID-19 by RT-PCR.
Thank you, Ha-Linh. Any other question for Ha-Linh? Please raise your hand. And also can use the WeChat, can use the chat box or the Google platform. Okay, Ha-Linh, can I ask you a question? How was the case was picked up? Because we have seen there's a community transmission also involved in this investigation. So how the case was picked up?
You mean that how was the case actually implemented throughout the course?
How was the first case picked up? Because she was symptomatic and she took a flight and landed in Vietnam. So how did you pick up the first case?
Yeah, can I have slide number 4? So she actually presented herself at the hospital herself after being very bed rest. Like she stayed at home for 3 days, but the symptom continued to be worsen every day. So yeah, she actually went to the hospital herself, and then the hospital had a procedure that whenever a person showing up with symptoms like COVID-19 compatible symptoms, they're gonna test for COVID-19. and then she was test positive for COVID-19 at the hospital, and then her I think her test result also sent to National Institute of Hygiene and Epidemiology for confirmation, and then we confirm her positive the very same day. So that's how she present herself there.
Just to follow up with Ha-Linh, I can't see any questions in the chat box, so I'm just continuing. Following your investigation, is there any recommendation for any kind of surveillance at the point of entry?
Yes. Can I have the slide number? Let me see. Can I have slide number 14? So actually, in Vietnam, after we saw this particular case with cluster with this kind of magnitude, this is also the first flight that we done contact tracing for all passenger and crew member on the VN54 flight, and also on every flight that we have positive case of COVID-19. We actually implemented throughout the course until the end of March, because we also see a lot of importation of case. But then we also done a lot of like immigration point entry testing, like you said. So we done systematic testing and quarantine for selected country. So selected country by high risk. So we start with like only European countries on the I think 12th of March, and then we extended to USA and Russia and other Asian countries, and by the end, like by 21st of March, we quarantine and test everyone at immigration point upon arrival, just to mitigate the whole need and the whole burden for contact tracing in the country itself, and just to have everyone quarantined right away when they boarding to Vietnam.
Thank you, Ha-Linh. There is another question from Dr. Muhammad Asri too. Do you have any cross notification for country origin of flight?
I think actually cross notification, you mean that when we found someone positive in my country and then notifies to other country as well. So actually is that correct? I'm not sure if I understand it right.
Maybe you can answer both. Did you get any notification from
Yes.
the country of origin, or have you notified to other countries?
Yes, so actually on this flight and for all the flight forward, whenever we have a COVID-19 case confirmed in Vietnam, we contact trace all of the people on the flight itself. So anyone who actually transit to other country, we also notify the CDC in that country as well. So for example, on this VN54 flight, we actually found one person who actually transit to other country and then test positive there in Cambodia. So we actually work with Cambodia CDC to notify them. And this goes similar to all the other people who also transit to other countries with the flight itself coming to Vietnam with COVID-19 cases. But for vice versa, we also have people from like Japan. We have Vietnamese people coming to Japan or coming to to South Korea, and then they test positive there, and we also get notification coming back, and then we do reverse contact tracing back in our country as well.
Okay, thank you. I have another question from Dr. Bino Arai from Malaysia. How do you think was the mode of spread within the flight? Airborne droplets, or could it be through contact or vomit in the toilets?
Yes, so actually during the course of the flight, as I say, I think in slide number 12, that aerosol and droplet transmission is highly possible inside the business class, even though that people, except for people who know each other, they actually, the index state actually set in the very far right of the board. So aerosol and droplet transmission is very likely, but also sharing meals together and sharing the same toilet is also a very high risk, because as you know, the business class have a very separate toilet with other class, so they share the same toilet together. So the vomit and sitting and talking to each other is also possible.
Okay, there's one more question from Philippines, Beans. If I recall correctly, there were 16 flights associated cases and 5 non-flight community cases. How could you be confident that they were associated with a flight case? and not community transmission from another source?
Yes, so the 5 non-fly community case we found because we interviewed all the fly associated cases, and we found out their list of close contact, and we contact trace them and quarantine them. And also for the close contact themselves, we also done standard interview for them and to find out if they have any exposure to other positive case or suspected case around them. So their connection to the only connection between the community case and between the fly associate case was that they found each other along the way. So there is only the only exposure that could be established, and with no other case around. So at that time, community transmission was not widely in Vietnam. We also have only 16 cases, and people were also very aware of the situation. So we very highly confident that the non-fly community case actually got infected from the fly case as well.
Thank you, Ha-Linh, for answering patiently for all these questions. There is a lot more questions for you coming through the chat box and also other ways. So I think due to the time constraint, we have to go ahead with the next presenter. But please, Ha-Linh, you are free to answer all the questions through the chat box. And also, if you have time, we will come back to the question at the end of the session. Okay? So please, thank you for your presentation. And now we will go to the second presenter. So if Mr. Surendra Mohan is in, Angela or the Secretariat, is he in? Yeah, I think I can see Dr. Surendra here.
Yes, ma'am. Good morning.
Yes, okay. Now we will go to the second presentation, which will be given by EIS Program India from Dr. Surendra Mohan Prajapati to give up his presentation on frontline response for the first coronavirus disease cluster in the largest state of India. So the time is yours, Dr. Surendra.
Sorry, can I just say, Dr. Surendra, could you, it seems like you may have more than one device that has a microphone that's on. Could you mute the other device, please? So we don't get the echo. Thank you. And then you can go ahead when you're ready.
Okay, thank you, ma'am. Good morning, everybody. Next. First cluster of COVID-19 cases identified in Agra district of the most populous state in India, Uttar Pradesh. We piloted COVID-19 surveillance containment plan of Government of India, described cases by time, place and person, and did contact tracing. Timely interventions prevented community transmission. Next. Last year, on 31st December, China alerted WHO about cases of pneumonia of unknown etiology. WHO notified India on 11th January. Thailand was the first country to report COVID-19 case outside China. India started airport surveillance on 18th January. Next. On 30th January, WHO declared public health emergency of international concern. India reported its first case. India's first indigenous cluster identified in North India on 2nd March, followed by declaration of pandemic on 11th March. Next. Agra is a city of Taj Mahal, one of the famous 7 wonders in North India. Population of Agra is 4.4 million with 45% urban occupancy. Team of EIS officers deployed to Agra on 4th March this year with the objectives of next. Piloting implementation of COVID-19 surveillance cluster containment plan and describing time, place, person distribution of cases. Next. EIS officers were deployed with effect from 4 to 28 March and descriptive analysis was done for the period of between 4 to 26 March. Next. We implemented cluster containment strategy by setting up district control room, assessment of healthcare resources designated for COVID-19 and mapping of containment zones. Next. We assessed human resources and space for setting up district control room and visited healthcare facilities for assessment of COVID-19 designated human resources and health infrastructure. We conducted meetings with district officials and planned for COVID-19 related trainings. Next, we mapped the containment zone around an epicenter. Containment zone was established around 3 km radius of epicenter for identification of cases and contacts and active surveillance for ILI cases for home quarantine. Surrounding 2 km radius was buffer zone, which enhanced ILI and SARI surveillance through the existing IDSP. Next, for epidemiological analysis, we obtained line listing of lab confirmed cases from IDSP Agra for time, place, person analysis. Next, we used standard case definitions of Government of India for suspect case, confirmed case, and high risk and low risk contacts. Next, district control room was set up with 514. Rapid response team identified 112 suspects and sampled 14 high risk contacts. Contact tracing team followed up around 1,000 case contacts. Area surveillance teams identified close to 3,600 ILI cases in the containment zones. Disinfection teams disinfected around 400 places, and call center team did 4,500 follow-up calls to quarantine cases and resolved more than 600 public queries. Next, Agra has 5 COVID-19 designated government healthcare facilities cumulatively. These facilities had 107 beds with 21 ICU beds with ventilators, 18 ambulances, and 60 doctors. Next, multiple trainings were given to 47 health professionals on surveillance, case definition and data flow, contact tracing, and infection prevention and control. Next, 3 containment zones were established. Containment zone 1 was identified around the cluster of 5 cases. Zone 2 was identified around the cluster of 2 cases. And zone 3 was identified around a single case. Next, close to 1,800 teams with 300 supervisors were deployed for ILI surveillance in containment zones. Teams surveyed more than 200,000 households and quarantined around 3,500 ILI cases for 14 days. As per Government of India testing strategy at that time, 4 ILI cases were sampled, none of which came positive. Next, contact tracing strategy included area surveillance and district control room activities. Out of total COVID-19 case contacts, there were more than 1,000 low-risk contacts and 14 high-risk contacts. RT-PCR was done for all 14 high-risk and 99 symptomatic low-risk contacts. 922 asymptomatic low-risk contacts and 108 RT-PCR negative contacts were home quarantine and followed up for 14 days. Their quarantine was considered complete once they were asymptomatic for 28 days. And those who were RT-PCR positive were admitted in isolation facilities and further contact tracing was done. Next, we also describe cases by time, place, person. Next. As on 2nd March, we case 1 and 2 were COVID positive. There 3 out of 5 high-risk contacts turned positive on 5th March, depicted here as C3, C4 and C5. In the second containment zone, C6 was a low-risk contact of C1 and C2 and found positive on 8th March. C7 was high-risk contact of C6 and tested positive on the same day. In the third containment zone, C8, the high-risk contact of a case with foreign travel history, tested positive on 15th March. Average contact traced per case were 27, range 4 to 58. Next. Median age of the 8 confirmed cases, including 5 males, was 38 years with a range of 15 to 70 years. 50% of the confirmed cases were between age group of 21 to 40 years. 3 cases had international travel history. Next, all 8 cases were hospitalized. Only one was symptomatic and one had comorbidity. No deaths were reported. Next, to conclude, we established 3 cluster containment zones and executed prompt responses by setting up of district control room, strengthening IIL surveillance, conducting trainings and contact tracing. Timely interventions with containment measures prevented community transmission. Next, based on the learnings from this response, Government of India replicated cluster containment strategy to other parts of the country, strengthened COVID-19 infrastructure by adding more isolation units, ventilatory support, and personal protective equipment. Next, these are my acknowledgements. Next, thank you very much.
Okay, thank you, Dr. Surendra, for this great presentation. And you have one question. They ask you to give the case definition for high and low risk contact. What do you mean by high and low risk contact?
Actually, I have added in slide number 30, 31st. Can you see that?
The next slide.
The next slide. Yes. High risk contact lives in same household or touch patient's body fluid. Direct physical contact without PPE, touch the linens of the patient, cloth or disease, and even in close proximity within 3 feet. Passengers in close proximity within 3 feet for a conveyance with a symptomatic who later tested positive for 6 hours. In our study, high-risk contacts were living in same household.
Okay, Surendra, the other question is from Dr. Intan Azura from Malaysia. Using the cluster containment strategy, how long we can contain the cluster?
We started with cluster containment strategy on 4th March, and till 28th March there were only 8 cases. Till 15th March there was 8 cases, and till 28th March no new case was generated. So it was about 28 days. We contained the.
While we are waiting for others to type in their question, I have one question to you, Dr. Surendra. You had something called containment zone, which is about 3 kilometers, and also a buffer zone of 2 kilometers. Why do you let that 3 kilometers and 2 kilometers?
It was decided by district administration according to guidelines of National Center for Disease Control. It was allowed to district magistrate and district administration to decide the containment and buffer zone as per their convenience.
Okay, there is one question from Dr. Tarun. How was community transmission defined? How could you conclude that this containment prevented community transmission?
This containment prevented community transmission because no new second generation case was generated. It was restricted to first generation case.
Any other questions?
Hello, this is Jiaping Su from Taiwan. I have a question for you. Thanks for your presentation. So in your slide 11, you talk about the enhanced IOI surveillance. Could you please provide us a detail about how did you do that enhanced surveillance of IRI? Thank you.
Hello.
So I know about the enhanced IRI and SARI surveillance. Could you please talk more about this surveillance? Thank you.
I couldn't hear your question. Please repeat. Your voice was breaking.
Yeah, I'm sorry. So you mentioned that you did the enhanced IRI surveillance in buffer zone, right? So could you please talk more about that? How did you do the enhanced surveillance? Thank you.
Yeah. In containment zones, there were teams who were doing house-to-house activity, but in buffer zone, we enhanced our surveillance by National Integrated Disease Surveillance Program, which already existed in the buffer zone. So we picked up the severe acute respiratory illness cases, SARI cases, from the buffer zone.
I think there is the same question is raised by Mani Gandanesen. Was there any specific reason to choose 3 kilometers? I thought you have already answered that, something on the local council provision, right?
Yeah.
Does that depend on any density of the population?
Yeah.
We have few more minutes. Okay, I think since there's no more questions, I think I would like to thank Dr. Surendra Mohan for sharing your presentation. Thank you so much.
Thank you very much, ma'am. Thank you all.
Okay, now we will move to the third presenter, who is DEbasis Kumar Shaha from FETP Bangladesh. He will be presenting on zonal approach to contain the spread of COVID-19 infection in a district of Bangladesh. Dr. DEbasis Kumar, please. The floor is yours.
Yes. Can I start, ma'am?
Yes, please.
Yes. Good morning. I am Dr. DEbasis Kumar Shaha, Fellow of Field Epidemiology Training Program, Bangladesh. I am going to present the findings of the piloting of the zonal containment approach to contain COVID-19 infections in a rural district of Bangladesh. Next. Bangladesh is a country of Southeast Asia having 148,460 square kilometers and around 160 million population. The first case was reported on 8th March 2020 in Bangladesh. Government closed the school on 17th March 2020 and declared nationwide holidays and provide ban of domestic travel on 23rd March. Office and local transports are reopened 31st May 2020. Till November 2020, COVID-19 positive case has been reported over 3 lakhs and deaths over 6,000. Next. As countrywide lockdown is difficult to implement, the government of Bangladesh took initiative to lock down zones instead of whole country from 9 June 2020 to mitigate the COVID-19 spread. All sub-districts are divided into 3 red, yellow, and green zones based on diagnosed COVID-19 cases per 100,000 population in past 2 weeks. Next. In Bangladesh, most COVID-19 cases reported in urban areas or in cities. So definition of zones are different. In urban, more or equal 30 cases per 100,000 population are considered urban red zone, and 3 to 30 cases per 100,000 population are yellow, and less than 3 active cases are green zone. In rural, more or equal 10 cases per 100,000 population are considered rural red zone, 3 to 10 active cases per 100,000 population are yellow, and less than 3 cases was green zone. Next. The objectives of our study are to compare COVID-19 positive case incidence and test positivity rates before and after zonal lockdown, and to assess whether zonal lockdown can be used as alternative to country lockdown to contain COVID-19 spread. Next. We conducted the interventional study in of Bangladesh from May 29 to July 9, 2020. We gave intervention from June 12 to June 25, 2020. Next. We selected a red zone in Narshindi Sadar sub-district, one ward named Birampur. The area of Birampur is 1.25 square kilometer with over 30,000 population. Here you can see location of Birampur. We selected the area as red zone as it has the rate of active cases was 72 for 100,000 population. Next. For zonal containment, we gave temporary boundary surrounding the area and restricted movement. There were one entry and one exit point, which were guarded by police and volunteers. COVID-19 testing booths were set up in the piloting area, which was open 24 hours every day. Food and medicine are delivered by volunteers 24 hours every day. Ambulance was present 24 hours in red zone area for severe patient transportation. Banner and social visits for using surgical masks by the community people and also award for social distancing. Next. We defined confirmed COVID-19 case if any person tested positive for RT-PCR for COVID-19 at Birampur in Narshindi, Bangladesh from May 29 to July 9, 2020. We also defined active cases. Any confirmed COVID-19 case of Birampur in Narshindi from date of diagnosis to 14 days. Next. We calculated incidence of COVID-19 by the number of reported COVID-19 positive cases in week divided by the number of population as expressed per 100,000 population. We also defined positivity by the total number of positive cases divided by the total number of sample tested. Next. For comparison, we performed Z test for two proportions, COVID-19 incidence and positivity rate, before and during intervention. We set P less than 0.05 as level of significance. Next. This histogram showed that reported COVID-19 cases in Narshindi district was increasing 11th April up to 12th June 2020. Next. This epicurve shows active COVID-19 positive cases of Birampur from May 29 to July 9, where May 29 to June 11 indicates the before intervention period. From June 12 to June 25 indicate during intervention period, and June 25 to July 9, 2020 indicates post-intervention period. 2 weeks before intervention, a total of 23 cases reported. During intervention, 7 cases reported and no case was reported in the following 2 weeks of intervention. Next, please. Here we see the weekly rates of COVID-19 confirmed cases per 100,000 population. Although in the first week of intervention, the weekly reported increased, which might be due to increased awareness of people for testing due to declaring red zone. The overall COVID-19 rate significantly decreased during and post-intervention period than the before intervention period. Next. Third figure showed percentage of positive tests in Birampur, Narshindi, Bangladesh, May 29 to July 9, 2020. The percentage of positivity in the collected COVID-19 samples significantly decreased during and post-intervention period than the before intervention period. Next. We have limitation in the piloting. The study didn't include control area, and long-term follow-up analysis were not done to see how long the area was disease-free. Again, findings of only one area might not give the representative result. Next. In concluding, the suggest zonal containment approach that could be used to control COVID-19 transmission in rural sub-district of Bangladesh. Long-term follow-up is necessary before implementing it throughout the country. Next. We are recommending to implement zonal containment in multiple areas of the country and analyze the findings to see the effectiveness of the approach. We also recommend to conduct a qualitative study in the population of containment areas to find out the acceptance of the approach in the population. Next. I am acknowledging following offices and institutes of helping me to conduct the study. Institute of Epidemiology, Disease Control and Research, IDCR, Director General of Health Services, HUI, and Field Epidemiology Training Program, Bangladesh, and other institutes of helping me to conduct the study. Next. Thank you.
Thank you, Dr. DEbasis Kumar, for your great presentation. There is one question from Dr. Bina Rai. Since we know that this containment was being done a few months back, so now she's asking what is the status of COVID in the area now? Is this a sustainable way?
Sorry, you need to unmute
yourself.
Yeah.
Sorry. Thank you. As far as I know, now this area is decreased COVID-19 transmission than other areas of Narshindi district. Because this study few months ago.
Okay, so the next question is from Dr. Tarun. Is it correct to label the cases detected by week as incidents? Could some of them be prevalent cases?
Thank you. Because we done two comparison weeks, before intervention, during intervention, and post-intervention. So maybe it see incidents, COVID-19 incidents.
Okay, one more question for you. Why zones were classified only based case per 100,000? Test positivity was not considered for deciding on lockdown, and the zone which tests less can have lesser cases.
Firstly, I say that it's a piloting approach. It's a zonal containment piloting approach in Bangladesh. And it is a sub-district of Bangladesh, and it is very close to capital city of Bangladesh. And capital city has international airports and many garments industries. So it totally depends on current data analysis and situation.
Thank you, Eldon. I've been missing your questions for a while. So this is a question from Eldon. How much resources were needed to maintain this containment?
We mainly local authorities like health authorities and administrative authorities helped us, and also many people, those are living in that area, that are the volunteers, they helped us also.
And one more question. Did those activities for containment also change over time?
Maybe it will be.
as the strategy being used for another place? There's an additional one more question.
We did this zonal containment another sub-district of Bangladesh. 4 to 6 sub-districts in Bangladesh is held.
So the outcome is the same, or is there any difference in the outcome from different states?
It depends. Not like this results. It depends, but close to this result.
While waiting for others to ask, I have one more question. Like, we have 3 zones, and you said there was a restriction of movement in the zones, right? So if
Yes.
a person staying in a red zone and working in a yellow or green zone, are they allowed to move and daily to go from the red zone to yellow or green zone?
No, it's totally restricted. The red zone people living in their house. We delivered food and medicine and others daily needs by volunteers to give their house.
So what about vice versa? People who are staying in green zone but working in red zone, are they allowed to go in and work in the red zone?
No, not at all.
It's a complete
totally different.
lockdown of the red zone.
Yes, totally different.
Any other questions from the audience? Someone typing. A question from Eric. Is it possible to cost what will be required to implement this in the other zonal area?
Could you repeat, please?
Is it possible to cost what will be required to implement this in other zonal areas?
Yes, it's possible. If anyone wants, it's possible.
And another question from Dr. Tarun too. How frequently did the zonal categorization change?
After 6 weeks, it will yellow zone. It will green zone, because we defined green zone less than 3 active cases, but we found no cases after 4 weeks intervention.
Okay, it's about 4 weeks. And there is one more question from Salim. How was the community engagement?
We inform there by miking and postering and awareness banner and etc.
So their cooperation was good?
Yes.
Or do you have any resistance from them?
Yes, they cooperated.
Are you following same? One more question from Sushil. Are you following same zonal approach in other areas now also?
No.
Why have you are you not following?
Because our country reopened 31st May, I previously said.
So you have released all the zones, so that means there's no more red zones.
No more red zones or other zones.
Yeah, so it's released. Okay, one more question from Eldon. What factors helped maintain the containment?
Mainly, they're strictly movement prohibited and COVID-19 testing regularly. Those have symptoms. And this is the most characteristics of containment.
Still question. You are very hot, Dr. DEbasis. Everyone is typing and asking you a lot of questions. So
no problem.
Okay, one more question. Was testing strategy and numbers same in all zones?
No, because we have case definition. Those have symptoms. We tested them.
Okay. Okay, I'm very sorry, Dr. DEbasis, for bombarding you with questions one after the other. You did very well. Thank you for your time and for your participation in this sharing. Thank you so much.
Thank you.
Okay, we have come to the last presenter for this session, who's going to be Suganya Barani from FETP-Chennai, India. And she will be sharing with us today use of cycle threshold or CT values in predicting infectivity of the individual in transmission of COVID-19. I welcome you, Dr. Suganya. You can start, Dr. Suganya. We can't hear you. Are you muted? Angela, can you hear me?
Yes. Go ahead.
But I can't hear
Yes. Dr. Suganya, you need to unmute yourself. Can you speak right now? Go ahead. Thank you.
We still can't hear you.
Dr. Suganya, we can't hear from you. We can't hear you. Yeah.
No, we can't hear you yet. Maybe the same thing like we had the same.
Dia kena log in, log out balik dan log in balik.
No, I think can you log in and log out very fast and see? Hotel to be right. 12:20.
Discussion, then 12:30.
Yes, am I audible now, ma'am?
Yes, we can hear you. Yes.
Please go ahead.
Good morning. I think that's the first glitch for the morning. I'm Dr. Suganya Barani. I'm a recent FETP scholar with the ICMR National Institute of Epidemiology, and I also work with the Department of Public Health and Preventive Medicine, Tamil Nadu. Our study was on the use of cycle threshold values in predicting infectivity of an individual in the transmission of COVID-19, which was done as a cross-sectional study in the month of August 2020. Next slide, please. There has been a lot of buzz around CT values and its role in predicting disease severity, in predicting infectivity in the SARS-CoV-2 transmission. We all know that viral load is an important factor in determining the likelihood of transmission of COVID-19. Aggressive contact tracing will aid in quick isolation of high viral shedders who may play an important role in infection and transmission among their contacts. Resource-constrained settings warrant measures that will save the time and efforts in identification of individuals who need to be prioritized and isolated. The cycle threshold values generated in RT-PCR assays have an inverse correlation with the viral load of the person infected with SARS-CoV-2. A positive association has also been reported between sputum viral load and disease severity, the risk of intubation, disease progression, and mortality also. With an assumption that CT values of diagnostic RT-PCR assays represent the viral load as a surrogate marker, we intended to determine its association, whether CT values could be used to estimate infectivity in terms of secondary attack rate, and also its association to common variables like age, gender, symptom status, and comorbidity among COVID-19 positive individuals to inform public health surveillance about utility of the CT values in resource-constrained settings like ours. Next slide, please. In order to find this, we intended to compare the cycle threshold values between the secondary attack rates of COVID-19 positive individuals. We also compared the cycle threshold values by age, sex, symptom status, and comorbidity of COVID-19 individuals. Next slide, please. We extracted data of 485 lab-confirmed COVID positives in 3 districts of Tamil Nadu state, reported in 3 days from the State Public Health Laboratory. We took variables of age, sex, and CT values from the lab's sample referral forms available with the laboratory. We extracted details about symptom status, comorbidity, and number of contacts who tested positive from the district surveillance records. Next slide. We calculated secondary attack rate of the list of COVID-19 positives. We then divided them into quartiles, 4 subgroups of secondary attack rate with less than 25%, 25 to 50%, 50 to 75%, and more than 75%. We calculated the median with interquartile range of the CT values for all the 3 SARS-CoV-2 genes, the E gene, the RDRP gene, and the ORF1b gene. And we also compared them by age, sex, secondary attack rate, symptom status, and comorbidity status. We tested between the groups using Mann-Whitney test, and we report 2-tailed p-values for significance. Next slide, please. The results, the median CT value across 3 genes ranged closely from 22 to 23. Next slide, please. The difference in median CT values of all the 3 genes was not statistically significant across subgroups of age. Next slide, please. Females had a significantly lower CT value in RDRP gene compared to males. Next slide, please. With the subgroups of secondary attack rate, there was no statistically significant difference of the median CT values across all subgroups of secondary attack rate. Next slide, please. COVID-19 positive individuals with symptoms had lower CT values in all 3 genes, with statistically significant difference in the E gene and RDRP gene. Next slide, please. There was no significant difference in median CT values between individuals with and without a comorbidity. Next slide, please. At the outset, CT values were not associated with secondary attack rate for SARS-CoV-2 in our setting. However, we have not accounted for contacts who have not been tested and for unknown confounders with relation to the cycle threshold numbers. This would have influenced our observed association of secondary attack rate with CT values, in addition to estimating the secondary attack rate itself. The symptoms and comorbidity status are self-reported. This information bias, if any, would have led to subgroup misclassification, thereby influencing the association with CT values. Also, CT values can vary based on the sample collection, type of sample, workflow, standard curve, and interpretation of the assay. However, we report findings from a single lab, assuming that the operational biases are nullified in this process. Next slide, please. In conclusion, from our study, symptomatic COVID-19 positive individuals have a significantly lower CT values, corroborating with a higher viral load among them. CT values are not associated with secondary attack rate for SARS-CoV-2 infection in our setting. Thus, CT values may not be of use in public health surveillance to predict the transmission of SARS-CoV-2 infection. Next slide, please. I would like to thank Dr. Manoj Morekar, Director of ICMR National Institute of Epidemiology, for his guidance, constant support. And I also thank the district surveillance teams of Kanchipuram, Thiruvannamalai, Ranipet, and Dr. Selvaraju for his contributions in data collection and analysis. Thank you.
Thank you, Dr. Suganya, for this wonderful presentation. Any questions from the audience or the participants? or fellow presenters? So let me ask you, the CT value been estimated only from the positive cases of COVID in your analysis, right?
Yes.
Or only positive cases?
Yes, ma'am.
So you said symptomatic patients had lower CT value compared to asymptomatic patients.
Among positive individuals, yes, ma'am.
Okay. So what do you think we have added value? Because you said there is no much public health study. So do you recommend us to do CT value for the cases, or what do you think from your experience?
There has been growing evidence, and I was not looking at the clinical aspects of a clinical perspective. I wanted to know if CT values could add some value to the public health surveillance, public health perspective, because by and large, we need some saving some resources by means of CT values and by giving the CT values to the district. So I think further research is needed in this area, especially when it comes to public health implications of usage of CT values. I think my study could conclude that symptomatic individuals have a higher viral load and they could be viral shedders and they could be isolated. But there's not enough evidence from my study to recommend it as for policy.
Yeah, I was thinking the other way around. So the lower the CT value, we don't have to do anything to the contacts, so that we can just leave them because they are not going to be that infectious, right? So I was thinking the other way around. So any questions from the floor? Okay, that's a question from Datuk Fazila from Malaysia. CT value is dependent on the test kit used. What was the test kit used and what was the normal value used?
I'm not sure about the name of the test kit used by the State Public Health Laboratory, but the reference value that they used to detect positivity was, the upper limit was 34 cycles.
Hello, this is Jiaping Su from Taiwan. So I was just wondering, can you talk a little bit about your, did you do the all tests on the same machine? Just as far as I know, the CT value is dependent on the not only test kit, but also the PCR machine. So did you do all the tests on the same machine? Thank you.
Yes, sir. All the tests were done by same set of people using the same reference value. That is why we took the data from 3 days, 3 continuous days from only a single lab. So we were making sure that the CT value differences from other labs could be a possibility. It has been said that the reference value is different for different labs. So we made sure that we analyze data from a single lab to nullify those other factors.
Dr. Suganya, there's a question. What specimen were used for testing?
Both nasopharyngeal and throat swabs were used.
We give few more minutes, see whether people are typing in or not. Okay, that's one more question from Meng Yu Chen. Was serology test included in your surveillance?
In the study participants, we did not use any serology data. This is just data from the RT-PCR assays.
Okay, if there is no more questions for Dr. Suganya, I would like to thank you for sharing your finding and also your research, what you have done. Thank you so much.
Thank you so much.
We have a few more minutes with all of you all. I think Alden have asked one more question, I think to you, Suganya. What is the relationship between CT value and sample collection? More virus in sample will have lower CT value. So what?
I guess there is an inverse correlation. The CT values is technically the number of cycles that is necessary to spot the virus. So it's a relative measure of the viral quantity. The higher the viral load, the lesser cycles we require to identify the virus. So there's an inverse correlation between CT values and the virus in the sample.
Thank you. And I'm not sure if Surendra is still there. I think there was one question for you from Eldon about your strategy on cluster. He says, do you think this cluster, I'm not sure whether Dr. Surendra is here. Are you here, Dr. Surendra? I think he has left, he's not here. So any other questions for all these four presenters? If anything, we have a few more minutes that we can take up. And there's one more question. This is for Suganya too. For secondary attack rates, you only reported the percentage. What was the number of secondary cases? Unmute yourself, please.
I'm sorry, at the back of my mind, I could not remember the exact number of secondary cases. I can get back to him on that one by referring to my analysis.
Yeah, okay, that's fine.
Sorry, Dr. Thilaka, it's Angela from Taiwan. So I have a question for Suganya, just to follow up with the last question. That was actually my question. Is that what I'm concerned is that, you know, when you only reported the secondary attack rate, we did see some that have very, very high secondary attack rate. So how were you looking for these secondary cases? Were they like within households, and do you think, you know, the different contexts of finding these secondary attack rates would affect your findings? Thank you.
Yes, thank you for the question. I was looking forward for the question to explain what are these secondary cases. We had actually, this is a work of the district surveillance. So the district surveillance teams conduct contact tracing, and they have a specific definition. Primary case and secondary case. A primary case is a primary contact and secondary contact. A primary contact is a person who is ideally from the household of the individual, positive individual. The secondary contact are those people from work, the people they meet in travel, and the people they had communicated or they had come in contact with in the past 3 days. So it is kind of blurry that who are the primary cases and who are the secondary cases. So when I started inquiring it, I just took the positive case in our study sample as the index case and traced all the contacts possible, took all the contacts, both primary and secondary, and found and identified who among them turned positive. So my secondary attack rates numerator would be the number of primary contacts plus number of secondary contacts who turned positive by the total number of contacts.
Thank you.
Okay, thank you. I think since there's no more questions I can't see any questions in the Google Sheet or either in the chat box. So I think with that, I would like to conclude this session by thanking all the 4 presenters who have extremely contributed excellently with all your investigation and also finding, and also given us a lot of information on these 4 aspects today. Thank you so much, and also thank you to the audience and participants for their active question and answer section. And thank you all. Thank you so much for this session, and I will hand over to the Secretariat to move on with today's day 2 conference. Over to you all. Thank you.
Thank you, Dr. Thilaka, and all presenters today. So right now we will going to have a break for 14 minutes. We will have a break for 14 minutes. So please come back and join us again in the next session. Thank you.